Good afternoon. This is Cynthia Ballar, and I am the co-chair of the Education and Training Task Force for PCPCC, along with my co-chair, Libby Baxley. And we welcome you to our webinar this afternoon related to education and training in preparation for a transformed healthcare system. We know we have to move away from the silo model of training health professionals for the future. And so we have a speaker today that's going to share some of her expertise in that area, but first a couple of housekeeping items. The presentation itself will be available within 1 day on the web along with the slides. In addition, if you have questions during the presentation, please type them into your question box, and we will end the presentation around 45 minutes and have a time for Q&A the last 15 minutes of the hour. Dr. Kubik is our speaker today, and Dr. Kubik is a real expert in interdisciplinary training. She's an associate professor at Eastern Virginia Medical School with joint appointments in the Department of Psychiatry and Behavioral Sciences and the Department of Family and Community Medicine. She's a certified cognitive therapist and founding fellow of the Academy of Cognitive Therapy, and her clinical and research interests are in cognitive behavioral therapy, eating disorders, psychological aspects of bariatric surgery, and primary care psychology. She also serves as the editor of the Journal of Clinical Psychology in Medical Settings. In 2010, she was awarded the prestigious Cummings Psyche Prize by the American Psychological Foundations for her work in integrated care. She has initiated a number of innovations in interdisciplinary training involving both family practice residents and psychology interns and postdocs, and we are very excited to have her with us today to hear about some of her efforts. Dr. Kubik.
Thank you, Cynthia, for that introduction. I'm very excited to be here to talk about something that is very near and dear to me. I have been doing interdisciplinary training, as Dr. Ballar said, since 1995 between family medicine residents and psychology interns. And I hope that as we discuss our interdisciplinary training model that we use at Eastern Virginia Medical School, that it will give you some ideas about how to co-train disciplines and to work more towards interdisciplinary interprofessionalism to create integrated care that we all envision. Okay, give me just a second. I'm trying to move my slides. Okay. As you know, integrated care fits well with a population health perspective, and it is a model that has gotten considerable increased momentum because of the public's Law 111-148, or more commonly known as the Patient Protection and Affordable Care Act. What is also important to recognize is that a recent primary care workforce investment of $250 million from the Affordable Care Act's Prevention and Public Health Fund in primary care professional training also is geared towards strengthening the primary care workforce across the board, as well as specifically in integrated care and interdisciplinary models. This slide is a picture of the New River Gorge Bridge located in Fayetteville, West Virginia. I don't know if I have any other fellow West Virginians on the phone, but I'm originally from Fayetteville, or actually right outside of Fayetteville, and I used this picture in a brief presentation on interdisciplinary training as part of a panel discussion that was given at the 5th Annual Summit for the Patient-Centered Primary Care Collaborative, as I feel the story of the bridge really serves as a metaphor for the role of interdisciplinary education and training and integrated care. On one side of this gorge, in the mid-60s, were numerous outdoor activities such as outdoor parks, whitewater rafting, mountain trails, and on the other side of this gorge were resources such as restaurants, shopping, entertainment, businesses. But the tourist industry in the area couldn't thrive because to get from one side of the gorge to the other took about 45 minutes of driving over very treacherous mountainous roads. When the New River Gorge Bridge was built in the 1970s, It was considered a magnificent architectural feat, as it was at the time the longest arch bridge in the world. It had an arch of 1,700 feet and was 876 feet above the ground below it. As soon as the bridge opened, the tourist industry thrived in West Virginia quickly in this area, because now you could get from one side to the other within 2 to 3 minutes. I like to think of this bridge as a nice metaphor for where we are currently in terms of training and where we want to go. On one side of the gorge, we have integrated care and the patient-centered initiatives. On the other side of the gorge, we have our current educational and training models. And I would say that interdisciplinary training is like a bridge that could connect the two, so that we can get from one side to the other much quicker. Because if we continue to train in silos, then we're going to have to retrain folks when they come out of their education programs to actually operate in the teams necessary for integrated care. We recognize that every profession still must meet its core competencies. So the shift towards interprofessionalism still takes into account the need for each profession to have its own personal identity, while simultaneously emphasizing the importance of team-based competencies. And this really does require a paradigm shift. It requires not just the skills necessary, for example, for me to be a psychologist, but for me to be a psychologist that can also effectively work with numerous other healthcare professionals and vice versa. In 2001, the Interprofessional Education Collaborative Expert Panel also very specifically created a report of the competencies that were needed for interprofessional collaborative practice in order to ensure that multiple healthcare disciplines were on the same page in regards to how to develop team-based skills. And in reality, Twiling, as early as 2000, I think said it quite well, that the distinction between medical and psychological has always really been arbitrary. It really has had more to do with the focus of how we trained people than with what the patients actually needed. The interprofessional collaborative practice competency domains fall into 4 main categories. And while there are 38 sub-competencies, I'm going to only quickly mention the main competencies that would be focused on during interdisciplinary training, and the ones that we have been using historically at EVMS, but have now been articulated very nicely by this interprofessional group. This group was comprised of representatives from nursing, osteopathic, as well as traditional medicine, pharmacy, dental, and public health. And recognize that the competencies needed seem to fall in 4 main domains. Values, which would be the ability for individuals to work with individuals of other professions while still maintaining a climate of mutual respect and shared goals and values. Roles, which is the ability to use your knowledge of your role in a particular discipline, as well as knowledge of knowing what every other discipline brings to the table to make sure that the patient's healthcare needs are met effectively. Communication, to be able to communicate with the patients, families, communities, other health professions in a very responsible and responsive way, so that we are actually preventing health problems, maintaining the health of the population that is healthy, and treating those who are unhealthy. And teamwork, where we're actually able to apply relationship building skills so that teams continually become more and more effective and able to respond to the needs of those they treat. For interprofessional education and training to be successful, we need the support of all stakeholders interested in primary care initiatives and collaborations. And that's why it's so nice to be able to talk to the patient-centered primary care collaborative audience, because we know that the PCPCC does have representation from multiple stakeholders. The activities that the trainees go through need to be individualized to fit with their varying needs, their abilities, how they learn. Surgeons learn likely very differently than psychologists versus pharmacists. So making sure that the interprofessional training maintains the aspects of training, again, needed to meet your domain or discipline-specific competencies as well as the general interprofessional competencies. And they really seem to work best when they rise from real-world experiences and create a model that actually allows the trainee to be able to step back and try to self-assess so that they will constantly be engaging in lifelong learning to be better and better team players. So to try to meet these kinds of educational goals, I'm going to go over a model that we've used at EVMS, as I said, since 1995. The model was actually in place before we had any grant funding and had been running actively for about 7 years. And in 2002, we were one of the first recipients of the Graduate Psychology Education Grant from HRSA. And that grant allowed us to actually take the model and improve it. And since that time, we've received 2 additional grants that have allowed us to even expand the model more effectively and to try to evaluate it more extensively. The Eastern Virginia Medical School is located in Norfolk, Virginia. Norfolk is part of the Tidewater area of southeastern Virginia, for those of you who aren't familiar with it, and it consists of 7 cities with a population exceeding about 1.5 million. We also provide services not just for these 7 cities, but also for parts of the eastern shore of Virginia, which is a very rural area, and parts of North Carolina that borders with us. When we started co-training psychology trainees with family medicine residents, we really had more of a co-located practice model where our specialty mental health trainees were in close proximity to where the family medicine residents were providing services and available for consultation and treatment of patients using more traditional kinds of services. As things have evolved, we moved more from co-location to collaborative care, coordinated care, and now I would say in most of our sites we have what is truly considered integrated care, where our trainees are treating patients side by side with the family medicine residents, and when there are more residents than there are psychology trainees, our psychology trainees are actually in the precepting areas and available for all residents when they have patient situations that arise. In our most recent grant, which started in 2010, we also started partnering with one, and hopefully in the future will another, federally qualified health centers in the area. This federally qualified health center that we partner with also offers training to internal medicine residents as well as our psychology trainees. The reason the model we use may be a helpful model for anyone on the call or listening to this webinar, regardless as to whether or not you are a behavioral provider, is that the patient-centered medical home focuses on an interdisciplinary team clinical approach, and behaviorists often have skills to facilitate team-based learning and team-based development. But they also, in addition to their ability to facilitate the teams, we know that patient-centered medical homes must screen for mental health, substance abuse, and health behaviors, and must have evidence-based protocols in place for common illnesses that are related to behaviors, mental health, and substance abuse, so that practices that are not integrating behaviorists onto their interdisciplinary care teams are going to have difficulty actually becoming and sustaining patient-centered medical home status. So this model will have relevance even if you're not specifically involved in training with psychology. The Eastern Virginia Medical School's clinical psychology training programs that are involved in our integrated care are our internship, which has existed since 1976 and is APA accredited. We take about 5 interns per year. We have a postdoctoral fellow specifically training in integrated care, and we generally have at least 3 psychology graduate students who are training in integrated care, and this year we will have 4. These graduate students are generally from the Virginia Consortium for Professional Clinical Psychology in our area, and the VCPCP is also an APA accredited PsyD program. These psychology trainees co-train with residents from the Eastern Virginia Medical School Ghent Family Medicine program, which has about 12 full-time faculty and accepts approximately 5 residents per PGY year and is fully accredited, as well as residents from the EVMS Portsmouth Family Medicine program, which is also fully accredited, accepts approximately 5 residents per PGY year, but is more of a community-based program. So our Ghent Family Medicine program is actually housed within the Academic Health Center, where our Portsmouth Family Medicine residency program is more in a nearby community. And then we have our third affiliation now with the Park Place Medical Center, which is our federally qualified health center located in Norfolk, approximately a 5-minute drive from our medical school. And they provide training for the EVMS internal medicine residents. So we do not specifically train all of the internal medicine residents like we do the family practice residents, but we get a chance to actually do some co-training with a small number of residents who are placed at Park Place Medical. At Park Place Medical, our postdoctoral fellow is there 1 day a week, and she is there the day that the internal medicine residents are there. And generally there are about 2 to 3 internal medicine residents present, sometimes 1 to 2 depending on whether they have other obligations. And the postdoctoral fellow goes in and actually sees each patient either with the resident or prior to the resident starting to evaluate the patient, and then makes recommendations to the resident and the medical director who oversees the resident's training experience there about what types of behavioral or psychological issues might also be relevant to whatever today's visit is about. Sample activities that we use to try to create interdisciplinary training is joint patient care delivery. That's our primary activity. Our psychology trainees round daily with our inpatient family medicine residents for our inpatient services at Centera Norfolk General Hospital, and they round 1 to 2 days a week at Maryview Hospital, which is the hospital that's located with the Portsmouth Family Medicine program. They also are in our Ghent Family Medicine Clinic and our Portsmouth Family Medicine Clinic, where they, as I said earlier, either often go in and see patients with the resident as the resident is seeing the patient, or when the number of residents outweighs the number of trainees, then the trainee will be available for any resident to pull that psychology trainee into a session as needed. The psychology trainees teach didactics within the psychology and the family medicine seminar series, 2 didactics that tend to have the most crossover are interdisciplinary case conferences, where we talk about all of the different aspects of the medical care of patients, or the primary care rounds. In the primary care rounds, we review rapid changes that are happening in the healthcare arena and the implications they have for education and training as well as for patient care delivery. Our psychology and family medicine trainees see psychology and family medicine faculty precepting together and working together so they have role models. We do specialized training in cultural diversity and the unique needs for faculty and trainees in primary care settings by helping them to look at issues about epidemiology in primary care settings and what kinds of problems present and how they might present differently. And then our psychology trainees also provide presentations, write papers, and pull together resources for our family medicine residents to help them with a number of commonly occurring conditions seen in primary care. The psychology trainees, when they provide services that actually fit effectively in integrated care. So they do not do specialty mental health services. They welcome interruptions and try to engage in the warm handoffs that we talk about a lot in integrated care. They try to create treatment opportunities that are more population-based. For example, currently we're doing a needs assessment, again, of our GET Family Medicine Clinic, and having, for 1 week, all of our patients complete an assessment, letting us know what specific kinds of groups or additional services for lifestyle changes and any kind of substance abuse or mental health-related issues they might have. We provide services both in individual as well as in group format. Common conditions that we'll treat in the group are depression or obesity. When our psychology trainees actually provide consultation or brief assessments and interventions, they're not only using very evidence-based approaches like CBT or IPT, but they also generally will treat the patient in 6 contacts or less, and the contacts will be 15 to 30 minutes or less. If we believe the patient is going to need more extensive care than that, then the psychology trainee and the family medicine resident will work together to make a referral to an outside specialty mental health practice, and then the psychology trainee will then help monitor and coordinate that care. Additionally, our trainees engage in program development and quality improvement activities that the clinic has by going to the meetings, sharing their ideas. They do staff training, patient-centered outcomes research, and the psychology trainees are also involved integrally at times with teaching the family medicine residents, specifically in areas most relevant to their skill set. For example, helping the family medicine residents meet their ACGME interpersonal communication skills competencies. We have, protocols that we use to have our residents come in and interview standardized patients, and then our faculty will give them feedback. And so our psychology trainees will also participate in that and giving feedback to the residents about, where their strengths and areas of improvement might be. We really underscore for the trainees the types of skills they're going to need to thrive in this area. So again, from the psychology perspective, we're trying to move away from kind of the specialty mental health siloed kind of mentality towards more of the skills that you need if you're actually integrated in the setting, which are really the ones that are centered around a practical view of confidentiality, what will and won't be shared, about what a patient tells you about their mental health status, how to be succinct, how to write documentation for primary care physicians that's quite useful, how to engage in diverse skills and be highly efficient. The average number of individualized patient contacts, you can see that most of our patients, and this is over a 6-month time frame, most of our trainees in psychology over a 6-month time frame are generally seeing about 330 to 340 patients in one or more settings. Based on our patient contact reports, which is one of the ways we evaluate our program to see whether or not the number of patients being seen seems to match the number of patients within our population that should be seen, shows that our patient population is very similar to what we'd expect in primary care in terms of it being slightly more female-based. Our setting tends to be largely either Caucasian or Black patients. We have some minority patients in other areas, but given our setting in Norfolk, that's pretty consistent with our population base. Our clinics primarily provide services to low and middle SES patients, and you can see that the services are provided across the age ranges. Most common reasons why family medicine residents and psychology trainees will work together on a case are mood disorders. 51% of our most recent cases were mood disorders. 11% of the cases are cognitive disorders. It's quite common that our psychology intern will be asked by the family medicine resident to come in and do an RBANS, which is a test of neuropsychological functioning. And within about 30 minutes, the intern will be able to tell the resident as to where the patient is functioning on a number of cognitive domains, including attention, memory, visual spatial skills, language. And that information is often used to make very important decisions about whether or not placements need to take place, self-care can continue, whether someone's driving license should be restricted, and so on. 14% of the reasons that there will be co-treatment are parenting concerns. Many of those about behavioral problems are ruling out ADHD. Anxiety and substance abuse are common, although less common in our setting, which probably means that they are likely occurring at a more common rate but not being identified and brought to people's attention as often as they should. And then 16% of the co-treated patients are actually being treated for issues related to non-adherence or other kinds of categories. We also do pre- and post-tests of knowledge for our psychology trainees, and then use the standard pre- and post-tests in the family medicine residency programs, such as the examinations that they would normally take. And then we do trainee satisfaction ratings. The next set of slides is from our most recent survey. It was completed in October, and we had a 53% response rate from the family medicine residents. I'm going to show you 10 slides showing what their opinion of cross-training with psychology was. And the starred items will show you the ones that seem to relate most to the interprofessional competencies themselves. The cohort of residents we have in general felt that the presence of psychology trainees had significantly enhanced the training that was available within the family practice residency. They agreed with the idea that working with psychology trainees enhanced their ability to treat psychosocial problems. They felt that the trainees improved communication that took place, improved family dynamics, and improved the ability of the culture to have mutual respect and shared values for what other professions could bring to the table. In general, they felt that working with the psychology trainees had helped them further define their role and the role of a behaviorist and know how roles were different and overlapping. They felt that psychology trainees being present at any given time increased the likelihood that they would investigate psychosocial issues with their patients, and that the psychology trainees at presence had led to an increased emphasis on psychosocial issues in general for the clinic, that the clinic was more likely to think about psychosocial issues as well as physical issues with their patients, treat them concurrently, and they agreed that they would likely be less willing to consult with a behaviorist if they were not in the setting with them. And as most of you on the call know, because I know you're invested in patient-centered initiatives, this is a common theme that if you can bring the behaviorist there, then the patients are more likely to seek services and the providers are more likely to refer for services. So this is also true whenever you're doing cross-training, that their presence seems to change willingness to discuss behavioral issues. Now, all programs have challenges, and we've certainly dealt with a lot of challenges to try to keep this program afloat and to try to make it one that meets the needs of all of our trainees involved. The challenges that we've met have been articulated in an article that Dan Bluestein, one of my family resident peers, and I wrote in 2009 and was published in the Journal of Clinical Psychology and Medical Settings. And I'm going to just highlight some of the most relevant challenges that we've had. When we started, and still today, some of the primary care patients are a little caught off guard or a little confused about why they might be being seen by two providers. Sometimes whenever they're seen by two providers and the one provider is designated as the behaviorist or designated as the psychologist, then they immediately want to question whether or not, in some way that they have, a psychological concern. And so we have to make sure that the primary care patients are well informed in advance why there are two providers in the room, what the two providers bring to the table, and we really emphasize, rather than focusing on the fact that there's a psychologist in the room, focusing on what that psychologist's purpose in the room is going to be. So we help them understand that, for example, this particular trainee is in the room in order to help us identify better ways to help you comply with your diabetic regimen. Or you've talked about a number of stressors and how they might affect your medical care, and this person will be able to help us tease out how to manage those stressors more effectively for you. So we do need to make sure that the primary care patients understand why those other providers are present and what they offer. The primary care providers have very large caseloads, as you know, and they need to prioritize what is addressed at each visit. And so the time pressures of those caseloads and the prioritization process at times has made it more challenging to integrate the behaviorist in, especially at times whenever some cases don't seem like they have as many behavioral components as others. And so kind of helping the providers over time to see how having the behaviorist, for example, at Park Place Medical go in before they go in and get that information, and it actually leads to a more helpful visit and a shorter visit, has helped overcome many of those concerns. And then our psychology trainees came in with very differing perspectives. Over time, we have recruited more and more people who have an interest or have worked in integrated care, but when we started our model, especially back in 1995, the trainees we were bringing in had very specialty mental health training experiences, and so having to help them sort through how to share information and write brief assessments and offer treatment in smaller units of time was a challenge. Other issues that kind of transcended discipline and went for are issues related to whether we're talking about our family medicine residents, our internal medicine residents, or our psychology trainees, was trying to help each discipline kind of learn each other's jargon, but trying to help each discipline avoid jargon when possible. We also had to educate psychology about common medical illnesses that they would see in primary care settings and the psychopharmacology that they would often see. We had to help the family medicine residents see how having psychology help with treatment adherence would actually improve chronic disease management, and get them to agree that chronic disease management was going to be a large emphasis for the training program, and getting everyone to realize that the pace and culture of primary care wasn't going to have to change rapidly by bringing more trainees in. And then again, teaching all trainees that, you know, common mental illnesses or substance abuse problems may actually present slightly different in primary care than they do in other settings, and so making sure that they are detected. Barriers that we have had the ability to work around was making sure that we got support from our top leaders. Without support from people that run the residency programs, the department chairs, the medical director at Park Place Medical, the training program couldn't work. We had to work around having institutional collaborators because when we first started to want to do cross-training, we had to identify people to do cross-training with. And so there are always collaborators available, but making sure that you can actually pull them in and get them invested. Practical issues has probably been the biggest barrier, kind of working around scheduling and curricular time allocations, making sure that our faculty have the skills to be able to teach integrated care, because our faculty had trained in siloed models, and now we're asking them to shift towards interdisciplinary education models, and so helping our faculty develop those skills over time. And we've done that in numerous ways by providing resources so that they can get training, but also by bringing resources in to do workshops with us on different issues about integrated care and how the disciplines can interrelate. Assessment of our program has been a real challenge because there just haven't been a lot of evaluative instruments out there yet for interprofessional competencies as well as for integrated care. And so over time, as more and more evaluative instruments are being developed, we are using more and more ways of measuring what we're doing. And then reimbursement models are definitely a challenge because while our program has been operational since 1995 and continued to operate for 3 years without grant funding, over the course of the 16 years, 9 of those years we did have grant funding, or we will have grant funding for, and so having the ability to reimburse this time and effort that goes in without grants is something that needs to continue to be addressed. So I'm going to wrap up with where we're hoping to go next and how the interdisciplinary training at our facility hopefully will evolve. We know that improving the training means that we have to generate a system that integrates medicine and behavioral health care across all levels, that continues to rely heavily on evidence, but also helps us target which patients need the behavioral resources the most, helps us utilize the limited time, space, finances, and organizational resources we have to our maximal potential, meets the needs of everybody in the process, is measurable, and is sustainable. So we are beginning to flesh out an idea, and this is still a process in evolution. And what we are moving towards is trying to come up with a way of using both the registry and the well-being screening methodology that we already use with our patients. Our well-being screening methodology is a variation of Abby Beecham's well-being screener that she developed in Colorado that we have modified to fit our specific clinic, and basically has the patients at their visit identify their stress level and answer 2 questions about sleep, and 2 questions about depression, and 2 questions about anxiety, and a couple questions about substance abuse, and also has a brief needs assessment on it. It takes about 2 minutes for the patients to fill out, maybe 5 minutes for a patient who has some reading challenges. And we're trying to use the registry that we would have, as well as these well-being screeners, to try to get better at placing patients in the 4 quadrants that the National Council for Community Behavioral Health Care has encouraged people to use. And then we want to obtain a baseline on utilization rates and then try a different model across the quadrants. Although some of you may be familiar with the quadrants, I'm going to review them quickly just so that everyone on the call recognizes what the quadrants entail. Quadrant 1 really looks at that patient population that has low behavioral and physical complexity and risk. Quadrant 2 looks at the groups of patients that have high behavioral health and low physical health complexity and risk. Quadrant 3 looks at those with low behavioral, high physical health complexity and risk. And Quadrant 4, the patients that have high needs in both categories. They have high behavioral as well as high physical complexity needs. An example would be a patient that is in our outpatient setting at GET, who's frequently hospitalized at our inpatient facility because he has both schizophrenia and diabetes, and his schizophrenia decreases his ability to engage in appropriate self-care with his diabetic regimen. What we hope to do is to, once we identify patients more thoroughly and place them appropriately in quadrants, is to try to be able to use a very patient-centered focus for each of the quadrants, where the energy for Quadrant 1 is really more on wellness checks, screening for those common mental health issues, and perhaps our well-being screening may be sufficient and the behavioral provider may not need to be present for those visits other than to do motivational interviewing to sustain that healthy lifestyle. So they will be very time limited in those interactions. Where once you get all the way up to Quadrant 4, those behavioral providers will become key to the provision of the service that is given and will be involved in the patient's visits each time that they come in. And to do this, we're also hoping, of course, this will require some creativity in terms of collaborations as well as funding, to try to match the quadrants with the level of trainees that we can pull into the system. At this point, we've largely focused on training family medicine residents and psychology trainees. We have occasional social work trainees in our environment as well under one of our social work faculty members. But what we'd like to see is bringing in of our psychiatry residency training program for especially those patients who are in quadrant 4, and bringing in our nutritionist and their training program, as well as, possibly expanding some of the medical student involvement and the involvement of nurse trainees, so that at each level within the quadrant, we have a determination kind of a priori as to which trainees may play the most vital role, knowing that at any given time this is a system that's in flux and that different trainees may or may not be as relevant as we think on the front end based on our screening and our registry. So that's kind of where we're hoping things will go as this continues to evolve. But in summary, I'd just like to say that what we're trying to do is to continue to make sure that we're creating interprofessional educational experiences that really help both the behavioral as well as the medical healthcare providers create understanding of each other's disciplines, an understanding of patient care needs, and how to work best in patient-centered initiatives. I'm going to stop there, and hopefully we'll open it up for some questions and answers.
Okay, thank you very, very much. This is very exciting work that you're engaged in there and very important for our field. And this gives me the opportunity to invite you to contribute to the brand new website that the Education and Training Task Force for PCPCC has launched. You can get to it from the PCPCC page, in which we are collecting, making a database of resources for education and training. And there are two kinds of entries that we're hoping that people like you and other people on the call will put in information about programs themselves, as this is an entire program, and then also a database of particular kinds of resources, whether it might be a particular course or a particular reading or particular pedagogy like shadowing or some of the role-playing methods that are used in education and training. So I wanted to bring that to everybody's attention, to go to the PCPCC website and to enter information so we can all begin to share more information about how best to prepare the workforce. But this is certainly a fantastic example of that. I have a couple of questions about some of the items that we went over earlier for people that perhaps came on later. The presentation will be on the website tomorrow or within a day or so after, and also the slides will be available as part of that as well. One of the questions that came up, Dr. Kubik, was can social workers participate in the training program? And I think you already answered that in part, but you might want to say a little bit more about that.
Absolutely. We've had probably just a handful of social workers in our particular training program. We have, as I said, one faculty member who's a behaviorist at our family medicine clinic who her discipline is social work, and so she is able to work with her trainees to make sure they're meeting their discipline-specific competencies, as well as integrate them in with the family medicine residents and the psychology trainees. Probably the best example of that would be our senior care clinic at Ghent Family Medicine, which is run on Tuesday mornings. Dr. Dan Bluestein oversees it, and the team actually consists of the family medicine resident, the family medicine attending, a pharmacist, our psychology trainee, and the social work trainee or the social work faculty member whenever there is not a trainee available.
Thank you. Thank you. Another question that arose is what training, if any, is provided so that patients themselves can be a key part of their own or family member's care team? How is, what kind of training of how to incorporate patients on the team is provided?
We at this point don't have specific avenues for doing that, but we have been looking at that as we've transformed further and further to patient-centered medical home. One of the reasons we started the needs assessment that we are doing at Ghent Family Medicine was with the hope that if we could identify what the patients wanted more specifically, that they could be more actively involved in planning this and kind of determining for us, for example, which level of services or which quadrant, if you will, they really would fit best in. So that's kind of a process that is in evolution, but I'm really hopeful, given that you've made the request that people put resources on the PCPCC's database in education and training, that other programs who have maybe resources out there that they've used more to pull the patient in would also be able to share some that we could use.
I think, yes, that's very good. I think also a core part of a lot of cognitive behavioral treatment does involve patient involvement, in the sense that it's not a treatment that's done to them so much as a treatment that they actively engage in and help determine along with their family members. So I think some of the behavioral components are naturals for involving patients in that role as well.
Absolutely, as is motivational interviewing and some of the other techniques that we use that pull them in once they've actually been identified as being treated by the dyad. Yeah.
Right. Another question is, how is billing handled for 2 visits on the same day? If, for example, a visit with an internal medicine resident and a behaviorist.
Because our psychology trainees cannot bill in the state of Virginia, billing is and is not an issue for us, in that it's not an issue in that only one person can bill, and so the person who does bill is the resident involved in the service. It is an issue for us in that, you know, if we were in a situation where our behaviorists could bill for the services, we'd be able to have more resources to funnel back into the education and training. But our behaviorists cannot bill.
I realize that's a significant barrier for these kinds of services to be self-supporting in a lot of areas, and that's something that, in terms of policy and advocacy, really has to be addressed. Another comment here: will the psychiatrist and pharmacist be co-located in the family medicine office? Will they do separate visits eventually, or will they always be seeing patients with the physicians during the visit?
We haven't made a final determination of that, but what we would hope is because these are trainees, that our psychiatry trainees and our family medicine resident trainees would actually see the patients together, so that the family medicine trainees could learn from the psychiatry residents. And our pharmacist trainees and our pharmacist faculty are generally on teams like our senior care clinic, where you really have complex medical issues across a number of types of medications, not just psychopharmacological medications. And so what we're going to be trying to do is put the trainees where they would best not only get the best educational and training experience, but provide the best patient care delivery.
Very good. With respect to the topic we had just brought up before, it says, if the psychology interns can't bill in the state of Virginia, how do you support the training program for them? We
support it through multiple avenues. Currently, part of their training is supported through grants. Part of their training is supported through funding we get through other lines, for example, the lines that they do at our hospital-based services. So they're able, we get a certain amount of funding for our inpatient psychology training lines, and then we allow those inpatient psychology training rotation interns to participate in the outpatient experiences 1 to 2 days a week without funding specifically attached to that.
Okay. And I think funding for education and training in general is a significant issue. Clearly, major healthcare systems such as Kaiser Permanente and also the VA learned that they needed to develop their own training programs if they were going to have a workforce ready for delivery of services in their systems. We have not yet had that extension to the private insurance group, but one of the things that I think will have to happen is the industry looking at that itself to see in what ways that we can support training, which often is an expensive endeavor. Another question here. Any ideas why your data collection you did not get a higher response rate from the residents? Gosh, I thought it was kind of high compared to the survey data that I see. But I think you said you got a 57%. response rate from the residents?
We got a 53% response rate, yeah,
Mm-hmm.
and we actually thought that was fairly high because most surveys that are done in our institution usually get about a 20 to 30% response rate. We kept the survey open for just a very short window of time. It was about 2 weeks total, and part of maybe the response rate was that some of the residents are actually on external rotations at any given time, and so their amount of investment in giving us feedback about what was happening at the clinic that they might not be currently rotating at may have been lower, but we thought 53% was a pretty good response rate overall.
It's a chronic problem.
Mandatory, yeah.
The chronic problem in survey research, I think, is an excellent point that this person raised. Any other questions from the listeners at this point in time? Nothing else is popping up. I did want to make a comment that several of the comments about what a great talk, and one person who said, gee, I wish this kind of training had been available when I was going through. And I think that's true for a lot of us, that we were not trained in these models. We learned it on the go. We learned what we needed to do to be able to provide good services and integrated care. And we don't want the next generation to have to go through what we went through that way. In fact, we can't afford as a country for that to happen if we're really going to have an integrated healthcare system. So this is a great example, and we certainly appreciate the time that you've spent with us, Dr. Kubik. And do you ever host site visits for those wanting to learn more about your model?
We recently had a request from some folks in Colorado that are going to come and actually visit with us for a couple of days, so we're open to that. If others are interested, certainly shoot me an email and we'll see if the pragmatics can be worked out. And I really want to thank the audience for taking the time to listen to the talk today, and I, as I said, hope that if they have resources to share, that they offer those to the website that you're developing so that all of us can benefit from each other's knowledge.
Right, right. I hope everybody will visit that website and start entering information. Thank you very, very much. Appreciate it. And for everyone else on the phone, have a happy holiday season and look forward to perhaps some more contacts next year.
Thank you.
The organizer has ended the session, and this call will be disconnected. Goodbye.